Hello and welcome to today's video on clinical guidelines and evidence-based practice in low back pain management. As clinicians, there are many issues which we are faced with day to day, which the guidelines sometimes have difficulty in giving us advice upon. And today's discussion is going to look in a little bit more detail on what these issues are. Well, if we summarise with what we do know and what there's reasonable evidence for, if we look at Cochrane reviews and the evidence base that is out there, we know that there's good evidence for avoiding bed rest. We know that there's good evidence for promoting relatively early activity. In other words, bed rest is not the mode of management as the first line of intervention, unless somebody is in a severe level of disability, which is likely to put them into a surgical category. There is a role also for using activity and quotas to guide the patient progression. And here, I think, from a clinical perspective, this is an area that really is not well addressed in routine practice. It's all very well telling a patient to go and do something and be active, but as clinicians we need to evaluate what the patient's current status is and attempt to define parameters which are safe for them to work within. The reason this is important to establish is that if we just in a blasé manner tell people to keep active and they do things which aggravate them, then we certainly lose credibility, and the recommendations that we provide lose some of their effectiveness. So I think this is a neglected area, and probably because it involves some analysis and some significant history taking in order to quantify what the current level of capacity is, and also to interpret what the progressive levels of loading are on the spine that are associated with functional activities that the patient wants to do. So as therapists we need to get a clear handle on that and actually put our head on the blocks. Obviously we need to recognize patients who display fear and anxiety characteristics, because there is an abundance of evidence to show that these characteristics can certainly perpetuate and predominate in a disability state. There's also good evidence that the therapist's attitudes and anxieties can feed into perpetuating so-called iatrogenic disabilities. So these are issues we need to be aware of. Sometimes our knowledge of pathology can sometimes hinder our systematic approach to loading an area. And of course advice. There's a lot of information now available about back pain, and in actual fact the evidence is conflicting. In some patients, if you give them excessive detail about the nature of their problems, this actually feeds into a catastrophizing behavior and can actually make them more fearful and more apprehensive. So the challenge here we face is giving appropriate advice to the appropriate individual, and that of course it represents a huge challenge, particularly if we're meeting patients for the first time, where we don't know how they process information, we don't know what their attitudes and beliefs are, and therefore we need to be very mindful of this, in that although it may well be well intentioned to provide information, there is an element of judging what's appropriate for each individual. What we may know with regard to the specifics of manual therapy, and as a manipulative physiotherapist I'm interested in this area, there are key areas which we have some information about. The role of specific stabilization for one, the role of spinal manipulation, and the Mackenzie approach. So there is modest amount of evidence to say that either of these strategies have some role to play in the management of low back pain. Now of course stabilization can mean different things depending on which school of thought you're coming from, whether it's the Paul Hodges, Gwen Richardson type approach to stability, whether it's the Shirley Sharman approach, whether it's the Stuart McGill, whether it's the general stability type work or functional training. So there are different interpretations of what stabilization training means. Spinal manipulation covers an absolutely massive spectrum of techniques, and therefore most of the studies don't really quantify in detail what types of manipulation are the most appropriate, and indeed differentiating between manipulation and mobilization. The Mackenzie approach has been shown to be of some potential benefit too. And it certainly has good empirical evidence and track record that it is part of a useful systematic approach to the management of patients with low back pain. And then if we look more into the specifics of what we don't know, and this really covers much of the day-to-day work which we as physiotherapists undertake, and I've distinguished these between active therapies and passive therapies. Active therapies meaning muscle stretching, postural training, general strengthening, specific strengthening, fitness and work hardening. So although our intuition is that these are useful things to do for patients, the evidence isn't particularly strong in their favour. In looking more specifically at passive therapies, we can look at joint manipulation, but again there are real lack of detail on the specifics. Massage, heat, acupuncture, electrotherapy, transcutaneous electrical nerve stimulation, and of course a raft of other passive interventions outside the scope of physiotherapy, but of course surgery, invasive pain management techniques. These are all passive interventions of which there is a very mixed review in terms of their efficacy. Those of you who are familiar with the NICE guidelines, that's the National Institute for Clinical Excellence in the UK, they publish guidelines on management strategies in acute low back pain, and some of their recommendations were very controversial because particularly from the anesthetics and pain management perspective, much of the existing invasive pain management strategies were not shown to be efficacious. So there is certainly some controversy in that regard. My opinion is that it is the patient selection for these type of interventions that has been at fault, and there isn't a specific enough workup done to select patients for appropriate invasive management, such as joint blocks, nerve root blocks, epidurals, ganglion blocks, and so on. I think as physiotherapists we haven't really been as forthcoming as we should be with identifying what we think should be the appropriate intervention for a patient. And remember, often we have the luxury of being in a position where we see a patient routinely over a number of interventions, and therefore we are in a good position to analyse what areas are prime areas of dysfunction and what areas are secondary areas, and therefore we can judge whether they are amenable to our interventions and whether we actually are observing a positive response, or whether the patient is plateauing or non-responsive, in which case we can make recommendations as to other interventions. So I think although the NICE guidelines are controversial, I think there is a scope for collaboration between pain management specialists and physiotherapists, but I think it requires a review of our existing practices and trying to look for more common ground, and of course systematic analysis of patients so that we can select the optimal care for each individual. See you again later.